Hello and welcome to the third in the webinar series focusing on intellectual disability and mental health. My name's BJ Murray and I'm hosting this webinar this evening. I'm the Operations Manager of Coast and Country Primary Care, and we would like to start by acknowledging the traditional owners of the land that we live and work on and pay respects to elders past, present and emerging. I would also like to acknowledge those with a lived experience of mental health that might be participating in this webinar. We have partnered with the Central Coast Local Health District and the PHN to deliver a series of webinars that build capacity on the coast regarding intellectual disability and mental health. And we're really pleased that you can join us tonight. This might be the first time that you've joined us. There's two other webinars that have been put onto the PHN's education website if you're interested in catching up on the information that we've previously sent out. Just some details about tonight's presentation. We'll have Dr. Dossiter speaking for the hour. Then we have time for some questions from 8 till 8:30. Questions will be monitored through the Slido website using the hashtag intellectualdisability2. So that's www.slido.com. And you put in intellectual disability and then you can put your questions in. So we'll be monitoring those questions while the webinar's on. So if something occurs to you, just send that through and we will be moderating those questions at the end after Dr. Dossiter's presentation. There's also a small evaluation that can be filled in, and we really love your feedback about the webinar series and tonight. So now I'd like to introduce our guest speaker, Associate Professor David Dossiter. Dr. Dossiter is a British-trained child psychiatrist with a special interest in intellectual disability and autism, and he's the team leader of the developmental psychiatry team at Children's Hospital at Westmead. He is a clinical associate professor at Sydney Medical School, and for 14 years till recently he was the area director for mental health for Sydney Children's Hospital Network. With the establishment of the developmental psychiatry team, he has worked to build capacity through collaboration and interagency partnerships in New South Wales over the past 20 years. Welcome, Dr. Dossiter. We are very excited to have you on the coast and looking forward to your information in your presentation.
Thank you, BJ. I too would like to acknowledge the Indigenous owners of the land here on the Central Coast. I'd also like to recognise those with a disability and their families who I so highly respect. Thank you for inviting me to present to the network of professionals working with children with intellectual or developmental disabilities on the Central Coast. I also wish to acknowledge New South Wales Health and Mental Health for funding the Sydney Children's Hospital Mental Health and Intellectual Disability Hub, which aims to improve capacity and skills across health and mental health services, including providing specialist consultations where needed in New South Wales, that Minister Bronnie Taylor launched 3 weeks ago. For convenience, I shall refer to intellectual and developmental disabilities, which includes autism, as IDD. The title acknowledges, and I should mention the title at this stage perhaps, is Are We Nearly There? Caring for a Child with Intellectual Developmental Disabilities, a Roadmap from a Developmental Psychiatrist. So the title acknowledges what a bold and massive social change and experiment we have with the development of the NDIS for children with IDD. I've chosen this topic to talk from the perspective of parents, partly because parents are our most important partners as a community that cares for children with IDD. I also think they're likely to have more influence on the politics of resolving the persistent weaknesses in our service systems. I've also chosen this topic partly because at the Children's Hospital at Westmead, we have a 15-year history of sharing and promoting ideas on helping children and adolescents with IDD, particularly with interdisciplinary and interagency audience in mind. And I wish to take a fresh perspective, which hopefully will still be pertinent for a professional audience. For example, our research has demonstrated the powerful effects of Stepping Stones parent training in special schools. And we were part of the massive community research intervention on the whole of the eastern seaboard of Australia. Our research with the Westmead Feelings Programme, Emotional Learning for Autism, has had an important impact on disability and mental health services and schools, and the online training I feel provides the best available clinical skills training for treating school-age young people with autism and improving their mental health. Through our schooling project on IDD, we provide a free-to-access journal for the mental health of children and adolescents with IDD, which has been going 11 years. And Meet Jessica is our video animation designed to raise mental health awareness with an award-winning Train the Trainer project for schools, community pediatrics and mental health in the bio-developmental, psychosocial, cultural model of understanding emotional and behavioural disturbance. A year ago, I did a presentation to teachers and school counsellors on what you need to know and what you can do for the mental health of children and adolescents with IDD. This is now part of a webinar series for teachers providing special education, looking at, for example, understanding and responding to behaviour in the classroom and supporting students with self-regulation. In July 2020, we launched the Sydney Children's Hospital MHID Hub Kids webinar series based on what is different about assessing and treating the mental health problems of young people with IDD. We were thrilled with the response to our webinar launch, with 500 people registering for the Zoom webinar and another 500 for the subsequently available podcast. We continue with a new contribution to this webinar/podcast curriculum with a new topic every month. And overall, we have 1,500 people who have registered interest in what we've made available. All of this can be freely accessed through our schooling website. This level of engagement reflects our experience as to how wide a professional community are concerned with this population. So to turn to the challenge of parenting a child with IDD. He who studies medicine without books sails on an uncharted sea, but he who studies medicine without patients does not go to sea at all. William Osler's 19th century quote is one of the enduring truths of medicine. How does this apply to caring for a child? When I was training in child psychiatry, a paediatrician friend asked me what he should read to be a better parent. I was surprised at this question, feeling that parenting was best learned from the experience of the way your parents brought you up, combined with life's wisdom. And as a friend, a paediatrician who I respected so highly, I felt he should be giving me advice on good parenting. Besides, psychiatrists are renowned for being experts on what goes wrong, not what to do right. Now, at the end of a career of 40 years in child psychiatry, I'm aware there is not just a lot of wisdom and experience, but considerable scientific evidence on how to care for a child with IDD. In fact, the whole knowledge base on how to care for a child with IDD has changed dramatically. And with that, the experience of growing up as a child with IDD has changed. Indeed, when I look back, my specialty of child psychiatry has changed almost beyond recognition. Albeit there's less research in the psychiatry of children with IDD, the role of neurobiology of a child's development is recognized, not just the social hardship of families. However, I've learned so much from the families I've worked with and looked for scientific studies that provide evidence to make sense of their predicament. Accordingly, I now feel that parenting requires reading, learning, and even training, as well as sharing experience with others in order to be a better parent. It's human to care enough to feel compelled to be a better parent than the previous generation. And in every generation, with the advancement of understanding, we can aim to do better. Accordingly, Osler's truth is about the need to face the uncertainty of the future with a framework or established road of shared knowledge. I would argue that the prevention and promotion of mental health in families, school and community is the most cost-effective health intervention and should generally have a higher priority in research and implementation. The plan for this talk is to start with the scale of the challenge, a framework for aiming for a quality of life for a child with IDD in the context of a family. Acceptance, primary prevention and mental health promotion through parent training. The importance of promoting development and independence with particular reference to emotional development and autism. The mental health and the biodevelopmental psychosocial framework and specialist ID mental health skills. How to get collaborative help from disability health and education. The burden of care, the handicap for the family, and then to conclude. So, the scale of the challenge. I've been privileged to have researched family life for an adolescent with IDD, and I'm still learning case by case from some remarkable individuals who care for these young people. In 1985, I did a research study of 4 hours interviewing of 92 different families with a teenager with high needs IDD. This gave me a breadth of experience and showed me how much these families love their children with IDD. Their accounts challenged the professional orthodoxy of the time that having a child with IDD was a persisting disappointment or grief for the dreamed of or anticipated child. However, this research also provided information and helpful understanding of these families beyond my years. Early in my training in the 80s, I witnessed the closure of the last of the institutions and hospitals in which children with IDD had been abandoned, and the slow development of community-based services. This was driven by the then new philosophy of normalization, the primary but excessively simple tenet of which is that without these institutions, these children would not be so handicapped and behaviorally disturbed. However, the first studies in the 80s of groups of families with the Down syndrome child showed they were showing that for 80%, having a child with Down syndrome was a rewarding experience. We now know that where that child with Down syndrome also has autism, that family life is much more challenging. In my own study, it was only 30% that felt life was good enough for them and their high needs teen with IDD. Against this, we know that 40% of children with IDD have severe and persisting emotional behavioral disturbance. And for those with autism, this goes up to 70%, with many additionally impaired by several disorders. Indeed, the research shows that comorbid emotional and behavioral disturbance has a greater impact on the burden of care than the developmental disability itself. Since the deinstitutionalization of young people with ID, community-based mental health services have been unprepared and unskilled, and the subspecialty has been underfunded. But understanding and managing the comorbid mental disorders is a key part of improving that quality of life. My own tertiary clinic audit shows that the mental health evaluation and treatment, particularly with medication, can reduce that disability by approximately an average of 20%. There are additional well-documented extra stresses. The increased chronic dependency of burden of care, an average of 7 hours a day, 7 days a week. The increased economic burden of about $15,000 a year. Parental burnout, stress, anxiety and depression, about 20%, and relationship challenge. There is no doubt that raising a disabled child can be a challenge, not that a neurotypical child is all easy. Having a baby always raises the risk that they may have difficulties, and up to 10% of babies have potentially disabling problems. What courage it takes to face this risk. For those who have a child with a disability, the process of acceptance and adjustment often takes a couple of years. But conversely, the disability often isn't evident for a few years. As we know, the number of children being placed into care is growing at a worrying rate, with approximately 15% of families placing a handicapped child into care. And of adolescents in care, approximately 30% have a significant disability. Karen Nankervis' research showed that the main reasons for family breakdown varies with the age of the child. Firstly, the problems of acceptance in infancy. Second, the burden of care in childhood. Third, the behaviour disturbance in adolescence. And fourthly, the family burnout and relationship breakdown in adulthood. Although there is an apparent life cycle sequence to these problems, when a family breaks down, all four factors tend to co-occur. These four challenges are what any holistic or person-centred service for disabled children needs to tackle. This talk aims to look for the answers. In 2010, I wrote on how much should we worry about the mental health needs of children and adolescents with or without intellectual disability, and how the rates of abandoning children in care and the rates of psychiatric disorder in children were increasing the Western world over. Wilkinson and Pickett provided evidence that this may be best explained by the rising relative inequity in our society. In 2013, the University of Sydney study called Left Behind showed that while there had been improvements for people with an intellectual disability in this time of rising prosperity, the gap had widened between them and the mainstream. We don't yet know what impact the NDIS has had on rates of employment, marriage, and inclusion, let alone mental health. A study looking at the factors associated with frequent attenders to our emergency department found similar factors of vulnerability predicted frequent attendances. That is, moderate to severe intellectual disability, financial stress, compromised carer capacity, and living in out-of-home care. Elsewhere, I've argued that psychiatric vulnerability or disorder is a measure of a lack of social adaptability. And conversely, we need to understand what is involved in achieving a quality of life, social acceptance and resilience, and lastly, community participation and contribution. Arriving in Australia in 1991 with my colleague Ken Nunn, our reforms in the Department of Psychological Medicine at the then Children's Hospital, including children with IDD, the same equity of access and respect as any other child for assessment and treatment. This equity of access to health services to people with disability is now written into law for all health and mental health services. Following on from my specialty training in the UK, I slowly found opportunities to try and help one family at a time with some of these most challenging difficulties, and in doing so developed partnerships with other highly skilled clinicians in New South Wales in paediatrics, psychological medicine and in disability. In a partnership between disability and psychological medicine clinicians, we established the only multidisciplinary interagency tertiary clinic in New South Wales, the Development Psychiatry Clinic, which in 2014 had an external evaluation by the Centre of Disability Studies at the University of Sydney, which found we provided world standard practice despite so little funding. With collaboration between some of the best clinicians in the state in mental health and intellectual disability, in 2005 we received funding to establish a multidisciplinary evidence-based curriculum on helping some of the most difficult children with IDD and their families. In 2011, we published our textbook based on this curriculum, which will shortly be available free on our website. And since 2009, our schooling liaison service for schools that cater for IDD has published a journal on the mental health of children and adolescents with IDD, free to access and available online. The Children's Hospital Schooling was funded to provide education, prevention, promotion, early intervention, and pathways to care between health, mental health, education, and disability. However, through our journal, the Journal of the Mental Health for Children and Adolescents with Intellectual and Developmental Disabilities, our main task has been to provide an evidence-informed viewpoint on what is novel, positive, and helpful for our troubled children and families. Although we were funded to provide interdisciplinary education and training, Parents are our most important partners and advocates for children with IDD. We aim to write the journal in plain English and therefore be accessible to parents. The elements of the curriculum for the mental health of children and adolescents with IDD were and still are: 1, aiming for a quality of life with the foundations of a shared evidence-based language and a biodevelopmental psychosocial cultural framework of understanding a child and their context, a focus on family and carers, interventions that promote skill development, intervention to promote mental health, and the integration of service systems. We developed this curriculum from an evidence base, what professionals thought was important, and have reviewed it in workshops and international conferences. I aim to signpost some valuable literature along the way. So my topic today is based on what I want to know, what would I want to know, and what I hope I might try to do if I had a child with IDD, and is based on our curriculum. This may sound presumptuous from a white male doctor, but I do so having shared many challenges that parents have had in making sense of a child with IDD, and witnessed their extraordinary love and skill to enable a good enough quality of life for their child and family. I also feel that parents of children with IDD are some of our most amazing community heroes. The framework of hope and aiming for a quality of life. The growth of a scientific literature on what makes a quality of life is still quite recent, but I feel it has some important lessons, one of which is that disability is not a strong factor to do with the quality of life. Neither is money an important factor, so long as you have an adequacy. The history of mankind has shown that, and potentially can continue to be one of evolution and progress, which involves valuing every person and their subjective experience of life as part of acknowledging fundamental human rights. This advancement of enlightenment is based on democracy, supported by science and the rule of law, and the hope for increasing prosperity. Accordingly, we should always be trying to build on the achievements of previous generations. Maslow described a hierarchy of human motivation and well-being, divided into healthy physiology, safety in life, love and belonging, self-esteem, and self-actualization, or physical needs, psychological needs, and self-fulfillment. Human advancement therefore involves the growth of well-being in our community. I'm struck with the similarity that this has with the domains that contribute to quality of life. No one has a perfect quality of life or complete self-actualization, but we can all aim for a good enough quality of life. Good enough parenting is a phrase that the paediatrician Donald Winnicott coined, implying that one cannot aim for perfection, as it's always balanced by our empathy for others. For example, Robert Cummins has done considerable research on quality of life, including for adults with intellectual disability, and finds that the key determinants are adequate standard of living, safety and shelter, health and nutrition, belonging and having valued relationships, being linked to the community, having a purpose and making a contribution to the community, and having a hope for the future. The components described creates aims for us or the young person with IDD to achieve a good enough quality of life. Indeed, he talks eloquently that the duty of politicians and government is to provide the mechanisms for much of this. A safety net for all, with access to housing, safety, nutrition, health services. To reduce discrimination against difference, to build self-worth, and enable community valuing and participation, including a valued employment contribution. He backs this up with rigorous research, community-based research. Now, babies are not small adults, but what is so wonderful and fascinating is we witness in children the growth of consciousness, self-awareness, and intersubjectivity. In those with IDD, we see the differentiation of this process happening more slowly. This includes developing skills in identification of self and non-self, motor regulation and coordination and sensory modulation, selective attention and attention switching, communication skills and theory of mind, mood regulation and empathy, self-concept and self-esteem, reciprocal social interaction and relationship building, reality testing, perspective taking, and other executive skills functions. These skills are best evidenced by the capacity of a young person to make new, good quality peer attachments. The most important skills are the development of attention and concentration, a prerequisite for learning, and the development of theory of mind, the capacity to appreciate that others have separate thoughts and feelings to your own, which is the central deficit in autism. It is this developmentally determined understanding of child development that explains what we need to do to foster optimal development as the child grows. So this is the model that we use in the Westmead Feelings program, where you start with behavioral and emotional regulation, followed by developing emotional understanding and emotional competence, which gives a capacity to developing attachments, leading on to, in primary school, social skills development, which leads to a capacity for peer relationships, and lastly, contribution to the community, which builds mental health and resilience. I find these models of the advance of man, the elements of quality of life, and the components of child psychological development a valuable guide for understanding children. It is the components of child development that predetermines the type of relationship capacity seen in childhood and determines what is most helpful to counter the challenges of disability, so that I shall come back to during the course of this talk. In 2001, I wrote an article, Parenting a Child with Intellectual Disability, The Chosen and Those That Choose. This review, based on Stainton and Besser's work, described that despite the additional adversities that some parents reported, that there were some advantages of caring for a child with a disability, such as the child is a source of happiness and joy, marveling at events and sequential small achievements in the life of their child. Parents report an increased sense of purpose and are giving priority to the elements of love, affection, caring, and simplifying life. Some parents reported expanded personal and social contacts and community involvement due to their disabled child, and added meaning to various relationships, such as learning who your real friends are and experiencing involvement in the caring community. Some parents reported that their child provided a source of increased spirituality and faith in humanity. Some reported bringing a family closer together. Sometimes their child with a disability was a make or break experience. There was increased tolerance and understanding, not just for the parents, but also for the siblings, not just for the disability, but for all human differences. Having a child with a disability was a source of personal growth and strength, persistence, bringing out the best in themselves. Lastly, this experience enabled them to have a positive impact on others, community, and professionals who were handicapped by their own pre-convictions or prejudices. This thematic literature on the difference of disability illustrates the fundamentals of what is needed to cope with any adversity to build a caring community for children. The implication being that mainstream families often live life in the fast lane and may miss out on some of these more personal and intimate experiences which are found when you face the reality of a child with IDD. It's important for professionals to appreciate such positives and work to enable such positive adaptation. However, most people who work in disability generally come with positive and altruistic intent. Acceptance should be modelled by health professionals from the time of birth. This modelling of acceptance of the wonder of new life is moderated with the acknowledgement that difference may create additional challenges for which there will be future answers. Developmentally, most babies are remarkably similar, and differences often only occur later in development. This modelling of acceptance provides a model that may be passed on to wider family and friends, and sharing the joys of a newborn child is key to the child's wider acceptance and engagement. Regardless of disability, the most cost-effective intervention to prevent psychiatric disorder is parent training. This can reduce violence and crime and the need for prisons, as much as reduce the need for psychiatric services and hospital beds. This evidence is so strong that I would argue that the privilege of government-funded education should require all parents to participate in parent training. This simple, universal intervention not only improves both disruptive and emotional disorders in the child, but improves parental mental health and marriages, as the success as a parent is so rewarding. Conversely, a failure in parenting leads to a cycle of worse child behaviour and in turn worse parenting. The best evidence in families with a child with ID is with Stepping Stones parent training. Stepping Stones Triple P is based on behaviour therapy, ABA, positive behaviour support, developmental understanding and the principles of normalisation. The principles involve creating a safe and positive learning environment, using assertive discipline, adapting to a child with disability, having realistic expectations, being part of a community and taking care of yourself as a parent. Strategies involve developing a positive relationship, encouraging good behaviour and new skills, and managing misbehaviour. Our own study in schools for special purposes was dramatic. As one school principal said, by the time a child gets their child into an SSP, a school for special purposes, the idea that anything that they can do will change the behaviour problem feels ridiculous. Yet the study reduced behaviour and emotional disturbance by 25% and had dramatic impact on parental stress, anxiety and depression, and their parenting skills and sense of competence. At the SCHN Mental Health and Intellectual Disability Hub, we are promoting some scholarships in Stepping Stones, both in the seminar version and the primary care version. And we'll shortly have a detailed presentation on Stepping Stones seminar version available as a podcast. Indeed, on Wednesday, our CPD is a presentation of Stepping Stones. Understanding delayed child development and the priority of behaviour intervention enables more normative behaviour for a child with a disability and is the first step to better mental health. A key element in success is reducing coercive parental behaviour while enabling skill building in the child's self-regulation. Building self-regulation is a key to protect your child from future mental disorder for internalizing disorders of anxiety and depression and externalizing disorders of ADHD and disruptive behaviour disorder. Despite the massive scale of funding, it's unfortunate that the NDIS has not yet appreciated the whole of life of priority that includes Stepping Stones parent training, early intervention, especially the potential for group Stepping Stones training. The economic evaluation showed that a year later, families that completed this program were $500 better off, as better behaviour enabled them to have greater access to employment. Because of the economic imperatives, I suspect a political solution will need to be found, either by the NDIS or the state government, which is what has happened in Queensland. But my child is different. I remember one child with Smith-Magenis syndrome who in my clinic started scratching himself when my registrar had accidentally touched him. And he went on scratching until he was bleeding through his shirt. Smith-Magenis syndrome is a genetic syndrome with a dreadful behavioural phenotype. But I've seen remarkable developments in the last 20 years in the management of these behaviours that challenge the best psychiatric services in the old days. Greater awareness of how challenging these children are has led to a small but remarkable improvements in outcome. Firstly, paediatricians are likely to recognise the disorder earlier, and it can be confirmed now by a genetic test. Secondly, the SMS parent group has had a huge effect in supporting parents faced with this challenge. SMS parents have supported the sense of feeling helpless that new parents suffer, which also enables a persistence of caring and behaviour management. These changes are documented in our textbook in Chapter 13 on parental perspectives. Here, two mothers of a child with SMS describe their challenges of how, as parents, they couldn't get a diagnosis or services. 10 years later, a third mother described the same biological vulnerability, but with superordinate patience and behavioural persistence was able to improve her child's behaviour. The fourth author, Judy Brewer Fisher, who is a national hero as an advocate for services for autism, argues that parents of children with IDD not only have to learn to care for their children, but also need to advocate for our wider society for the acceptance and service provision of these children. Mutual parental support from those who have lived with the lived experience is also really valuable. A strong focus of the traditional child psychiatry movement has been helping parents to overcome their own adversities to help emotional behaviour disturbance in the child. In high-needs disabled children, it is now recognised that the biological difference is a greater determinant of future disturbance than any family quality, not just in SMS, but in autism and in fetal alcohol spectrum disorder and other examples. That said, the parents of children with SMS show that superordinate parenting still makes a difference, but also professional standards of parenting that is taught in stepping stones remains the best evidenced intervention, even for extraordinarily disturbed children such as those with fetal alcohol spectrum disorder. To summarise, 2-year-olds are recognised as the most violent beings on the planet, and the role of parents is to teach them self-regulation, emotional recognition and socialisation. This does not happen without skilled parenting. In those with IDD, the challenge is greater, but these higher level skills are readily taught to parents, and failure to optimise parenting causes greater hardship and cost to all, especially if it leads to long-term family breakdown. Conversely, emotional behavioural disturbance, behavioural regulation are the first requisites for developing closeness to the parents and other family members. It's also key for developing and integrating a subjective sense of self as concentration and theory of mind develop. Promoting development and independence, especially in the context of autism. Along with behaviour management, it's important to understand the different domains of development. Where there is a delay in development, it's likely that delay will be uneven, and therefore a parent needs to both understand the domains of development and look for skill development across these domains. The main domains of development that progress with mental age are as listed. 1, motor and sensory development and integration, including coordination, sitting still, and calmness, a prerequisite for concentration. Independent skills, for example, dressing, eating, hygiene, toileting skills. These are the best measures of general intelligence before developing the 3 R's. Communication and language, receptive, expressive, verbal, non-verbal, including object and picture communication. Emotional, social, and play skills, the most complex skill. It's difficult to measure, but we have well-recognized descriptions of the sequence of these skills. Quality of imagination, stereotypic rigidity or imaginary preoccupation at the expense of social interaction versus the ability to build reciprocal ideas. Lastly, educational community integration, keeping safe, accessing services, managing money. Schools are the primary setting in which these skills are tested and developed. Promoting skill development, even in small steps, is key to independence and self-efficacy and can be supported by specialist disability allied health professionals such as physiotherapy, occupational therapy, speech therapy and behavioural therapy, which can now be funded by the NDIS. All these domains of development have complex genetic factors driving their processes, but the pattern of delay will influence behavioural presentation. A developmental age framework is necessary before one has educational skills, as psychometrics have limited validity before you have the 3 Rs. Further, parents usually know these stages from their knowledge of neurotypical children. In my own study of high-needs children with IDD, I found that behavioural disturbance is not related to chronological age, but to developmental age. As Lorna Wing, a mentor of mine and the founder of the UK Autism Association, pointed out, as a child's mind develops, they become more exploratory, energetic and intrusive until their capacity for theory of mind develops at the developmental age of 2.5 years, when not only do they become more aware that other people have thoughts and emotions separate to them, but they develop a capacity for thought and imagination into which to direct energy, and their externalizing energy settles down. Autism is the specific delay of the development of emotional understanding and theory of mind that leads to problems of empathy and cognitive rigidity or stereotypies. Accordingly, a child with autism still has emotional understanding under the age of 2 years, and one that Asperger's is under the age of 4.5 years developmentally. This delay in emotional intelligence is what also needs intervention. There's a growing literature on how the stage of emotional development is a critical determinant to mental well-being in children and adolescents with IDD. Other factors that contribute to whether a child is easy or difficult to raise include health problems, including neurological and sensory deficits, intellectual ability, including learning problems and neuropsychiatric deficits, temperament with genetic and environmental contributors, environmental milieu, the emotional warmth, stimulation, predictability and consistency, earlier experiences, whether positive or traumatic, attachment style and strength, all contribute to development and neuroconnectivity and also to vulnerability and resilience. Children that are a greater challenge, e.g. with autism, are more likely to have an impact on family functioning. In fact, genetic differences in the child elicits differences in the parenting response. In terms of psychological development in IDD, teaching emotional recognition skills, emotional perspective taking, and emotional problem-solving skills is key to developing attachment and social relationships. In the Westmead Feelings Program, Emotional Learning for Autism, our dictum is you can't have social skills without emotional skills, which is what the Westmead Feelings Program targets specifically. In this part of my talk, I'm really only setting up signposts for important areas of literature. Interventions to promote skill development have a growing literature, and in our textbook, the topics include sensory integration and motor development, promoting communicative competence and alternative and assisted communication, building life skills, developing emotional-based social skills in autism and in intellectual disability, promoting healthy sexual awareness and relationships, and lastly, transition. The journal has additional valuable articles. For example, Learning to Move and Moving to Learn is an article I wrote from Amanda Kirby's work on the problems that are associated with motor coordination disorder, and shows how interconnected different disorders of development are. So, mental health and the biodevelopmental psychosocial cultural framework. Comorbid psychiatric disorder. Identifying a comorbid psychiatric disorder is important. In those with autism, 50% have ADHD, and 50% have crippling anxiety. The critical element is that the emotions or behaviours are more handicapping than one would expect for the development and opportunities for learning better behaviour. mental health awareness is critical for identification. For example, I've found some special education teachers may be highly skilled in behaviour management, but don't consider the possibility of the additional biological handicap of ADHD, when reasonably straightforward medical treatment can be so helpful. Conversely, identifying crippling anxiety in a child with limited communication is difficult unless you're carefully considering this option. I think we've come a long way in the last 20 years when different agencies were using different terminologies according to a particular ideology and discipline. Parents, along with their professionals, need to consider different models of understanding behaviour and work out in collaborative ways the most valuable model for each problem in a child. Indeed, the study of behavioural phenotypes teaches us that different presenting symptoms may have completely different causal mechanisms in the same child. I have real concerns about some of the discriminatory ideology of the NDIS, for example, for restrictive practice, when they attempt to deny young people with IDD access to pharmacological treatment by ascribing it as a restrictive practice, or failing to recognise the need for assertive discipline and control when a child with IDD acts without insight or clear intent, secondary to their developmental delay and their need for safety management. Safety management is an important consideration in many persistently violent disabled young people, and I use my article on this topic in our journal more than any other to educate parents and disability professionals. The need for skilled assertive discipline was illustrated by a recent comment of the Royal Commission into the abuse of children with intellectual disability when a school claimed a disabled child was being deliberately violent. And the Commissioner advised that in Australian law, any child under the age of 10 cannot be considered to have intent. What a responsibility we share with parents and as a community to show responsible management for disturbed children, which often needs multidisciplinary understanding and skills to establish an optimal reactive management plan. Interventions to promote mental health. Key elements from the curriculum and the textbook. Firstly, promoting safety and resolution. Higher risk behaviours of violence or self-injurious behaviour often need multidisciplinary intervention, as described in our chapter on safety and resolution. This also took a systems approach to examining the effects of a child's perception of different agencies and professionals on their problems. Unfortunately, such a service no longer is available. Parents have to make these judgments themselves. They have a powerful legal authority to keep their child safe so long as they don't inflict injury. Approaches start with behaviour management, consideration of comorbid psychiatric disorder, and then safety management. Safety management of its own can be highly therapeutic, and any intervention has to be judged by the outcomes. Chapter 22, Graham describes the modification of CBT and counselling. Modification of trauma-focused CBT is also important, but mostly for those with mild IDD. Regulation of arousal, Chapter 23, looks at relationships between development, trauma, attachment, anxiety, and how extreme distress also affects the response of carers, which in turn contributes to the problem. Intervention and repair are therefore a complex multifactorial process. Psychopharmacology is often a necessity when non-medical approaches have failed. However, there are differences in the way mainstream medications may react in those with IDD, and often different medications are needed. My own clinic audit of 150 cases found they had an average of 3.5 diagnoses, excluding the developmental disability, and required an average of 2.5 different medications for the best outcome. I've recently summarised my approaches to the evaluation of need and the use of medications in this population. In my training, my mentor taught that any doctor who wishes to help high-need young people with IDD has to be prepared to prescribe. When I first trained, ADHD was a controversial diagnosis, and in the UK, medication was seldom used. Now ADHD is a well-recognized biological and genetic disorder for which medication is established as the most effective intervention. The importance of biological diversity in children has been slowly established, and medication is an important treatment in more impairing emotional behavior disturbance. Pediatricians are generally skilled in identifying these problems. This graph is a bit complex, but it's a summary of the treatment effectiveness of different approaches in kids with intellectual disability and autism. So on the left, we have the effect size of an intervention, and on the y-axis, we have the strength of the evidence. So if we see systematic review, the highest level of evidence is only found for special parenting skills and behavior therapy, or even behavior therapy has limited long-term benefit. The color scheme is to show the rate at which these have effects, so that, for example, parent training takes a few weeks to months, whereas medication can be a few days to a few weeks. Then the mainstream areas are things like special education. Well, that's a very powerful psychological intervention, but it takes months to years to work. Then there's CBT and social skills and speech therapy and family therapy and occupational therapy. And most of these therapies have both case studies and control studies, but rely a lot on professional consensus. So there is a huge amount of evidence, but they're not at the level that most of medicine works, with multiple randomized controlled trials. At the other end of the spectrum, we've got things like stem cell therapy or chelating agents or dietary treatments, for most of which one wouldn't recognize. But safety intervention is one of those areas which can be dramatically effective and is very seldom considered. So much of the therapeutic evidence depends therefore on cohort studies, professional expertise and consensus. But mainstream clinicians often mistakenly dismiss the lack of high levels of methodological evidence as an absence of evidence. One research study illustrated that parents of children with autism are particularly vulnerable to alternative and unvalidated treatments in the early years, but over time come to accept views more in keeping with professional consensus and scientific evidence. Similarly, parents have to judge when a therapy is not providing useful benefit. The business model of the NDIS may present a conflict of interest versus what is in the best therapeutic interest of the child. In this free market economy of disability, we also lack systems of evaluating the quality intervention from different service providers. And then in other settings, find there are no providers provide a prescribed service at all. I know some advocates despair at the quality of positive behaviour support provided by NDIS registered practitioners. And disability advocates have a critical part in to play in the workforce to see community justice in accessing service systems. So this slide looks at the definitions and the language used for describing mental health, which is often confusing. And there's often this lack of common professional language. Different agencies may fail to understand different perspectives or misuse them to avoid providing a service. So in this slide, we have mental disorder and mental illness, which is really what the mental health services deal with, and is considered in the National Mental Health Plan to be about 3% of the population, and deals with patients that present with impaired reason in emergency departments with major depressive bipolar disorder, schizophrenia, and acute mental disorder. At the other end, we have mental health and well-being, which is really what everyone's concerned about, is promoting resilience to cope with normal life stresses, improving attention, restlessness, behavior, reciprocity, etc. We then have challenging behavior in 40 to 60% of kids with ID. And this has traditionally been managed by disability services, looking at aggression, self-harm, behavior disturbance, stereotypies, habits and pica. But then there's a whole range of other mental health problems, such as ADHD, ODD, ASD, depression, anxiety disorder, OCD, lability of mood, panic disorder, dissociation, trauma-based symptoms. And often these don't get access to mental health services, and largely they're managed by pediatricians in this society. But they need the backup of specialist mental health expertise. But partly the problem is that this is often seen in private practice and not part of the public health system, creating a disconnect. The policy guideline between disability and health agencies used to be that there is no wrong door, and there was an important memorandum of understanding of collaboration between disability and mental health, which is now redundant with the NDIS. However, I contend that mental health is the most important and underfunded area of health. Mental health services are understandably defensive as they're generally overwhelmed. NDIS is a massive enhancement of funding for people with disability and more than twice as big as mental health services of all funding types. Yet, as a massive banking insurance scheme, it has no mechanism for collaborating with mental health. In the days before NDIS, ADAC was the main resource for emotional behavioural disturbance and disability, and the emotional behavioural disturbance was probably half of their professional work. The lack of collaboration with mental health risks an attempted massive cost shift for behaviour problems from disability to health. The scale of the problem will continue to trouble politicians as it remains wedged between state and federal funding systems. What can parents do in the meantime? Health literacy is the term used for the level of knowledge and skills in understanding health problems and accessing health services. It is my view, in dealing with complex children with IDD, a parent needs to become an expert on their own child's problem. And as a psychiatrist, it's valuable if they keep the records, including what medication they've used in the past and what the effects or side effects were. None of us like to depend on health professionals, but when you need one, make sure he or she is someone you can trust. This starts with a good GP to be available for intercurrent health problems and a general paediatrician to coordinate inputs from a range of professionals from health, disability, education and NGOs. You need a GP who knows you and your family and has the patience and understands what helpful assessment can be made despite a child's limitation of communication or behaviour. As a problem becomes more challenging, high risk and resistant to intervention, is likely to need a wider range of skills in a multidisciplinary, multi-agency tertiary team review. The range of skills might include pediatric, psychiatric skills to assess health and mental health, multidimensional formulation of medication, multidisciplinary allied health skills including clinical psychology, OT, speech therapy, special education, pharmacy, case management. Skill building approaches as described above, specialist therapies for such as emotion-based skill learning, play therapy, modified or trauma-based CBT, family systems assessment and management skills which may be different to mainstream families. Cultural knowledge is often needed as cultural difference can affect health literacy and access. Awareness of child protection and human rights issues and the interface with DCJ and the care systems of those in out-of-home care. No one agency has all these skill sets, so lastly, there is a need for a high level of interagency collaboration. It's no wonder that parents often develop professional proficiency in managing collaboration because of the range of services and professionals and skills involved. Integration of service systems probably remains a major and complex challenge, with a growing literature on how it can go wrong, as we had in chapter 27, and what approaches can enable constructive collaboration. And some resource-intensive approaches on how to build solutions, such as the intensive services response, which health has now shut down. Probably it works best when a parent takes control of this. In a responsive service, one should hope that a more complex problem would naturally engage more professionals and a greater range of expertise. In this diagram, I try to describe this community-based management of ID with increasing clinicians and agencies, the more complex the problems became from tiers 1 to 3. With tier 5 being acute response and tertiary problem solving, and tier 4 being the interagency problem solving conference. I know there is expertise in the NDIS and NDIA to realise we need this service again. And reason would suggest that at some stage in the development of the NDIS funded services, this will need to be developed again. There is no doubt the additional NDIS funded resources has helped many families. I'm encouraged that so many professionals from different agencies are interested in the evidence-based biodevelopment psychosocial cultural model of mental health and ID. I feel that education and support for specialist approaches is helping to improve collaborative systems in health and education. Over time, although we see that home is the most important influence, schools are appreciating that they are the second most important influence on the mental health of our children and becoming more skilled and programmatic in working to build mental well-being and resilience. The biggest handicap with a child with IDD is the additional burden of care for the family. 7 hours a day, 7 days a week, way beyond when one expects a young person to become independent. Possibly the empowerment that arises from stepping stones parent training can have a strong effect, partly through improving behaviour and partly from engaging family and friends to be part of the child's life. It helps with parental helplessness and self-sacrifice that I often see leads to dangerous violence when the adolescent with IDD becomes bigger and stronger than the parent. The NDIS doesn't directly focus on supporting carers. They do provide indirect respite in terms of support for community access and other independence-enhancing activities. I have seen the impact of in-home support breaking the intensity of behavioural dysfunction, for example, between a fraught mother and a self-injurious teenager. It can also help with the domineering teenager who never leaves his room or his social media for what can be years of stagnation. When I was writing this talk 3 months ago, I wrote that the NDIS had to accept the reality of the need for residential voluntary out-of-home care, emergency respite, and even share care arrangements for some of the most demanding and sometimes impossible young people with IDD. However, recent experiences raise doubts about their intent and the status of voluntary out-of-home care as a category of DCJ service provision. There is no doubt that there are massive costs for family and society for a failure to intervene early and prevent total family breakdown. As I understand it, disability services are responsible for challenging behaviour, and most violence is not due to mental illness, although they often overlap. However, the interaction with NDIS and DCJ is a problem area which need greater development, particularly systems for complex cases and ready access to the complex support needs pathways. In a similar vein, there's a lack of cooperative systems between mental health and the NDIS-NDIA, which is critical to provide the best multi-agency, multidisciplinary care for complex cases. Parental well-being is critical to the well-being of any child, including those with IDD. Families are the building blocks of society. They're both the source of emotional communication and practical problem solving. Families depend on structure, rules, and accountability with rewards and consequences for every member of the family. They are the source of love and welfare emotions, as well as providing practical resources. Relationships are healthier with appropriate closeness, not too enmeshed and not too remote. And managing emergency emotions. Emergency emotions include anger, anxiety, depression, or rigidity, for example, from OCD. And they are highly infectious and can have harmful effects, even if another member of the family experiences a different emergency emotion. GPs and paediatricians need to check out the well-being of the carers they consult to, as the parent-child relationship is part of patient-centered care. Family isolation also contributes to mental health problems. To conclude, a parent of a child with IDD needs to become a developmentally attuned behavioural expert for their child's well-being, but also their own well-being. They clearly need medical support for the increased risk of health and psychiatric disorder, which is mainly managed by paediatric care. CAMS are skilled in the community management of supporting family relationships and major mental illness and disorder. We also need skilled clinicians in other specialist disability-based disciplines in helping a child with IDD. Schools have a key role in adequately supporting special needs, not just for education, but for building emotional skills and peer engagement, with greater empirical focus on building mental health and resilience. These families need social support from wider family as friends, as well as personal support and community access, funded by the NDIS to cope with the burden of care. The NDIS has made progress in providing support for skill development, but skilled NDIS-funded positive behaviour support remains critical. There is now an NDIS system for recognising complex support needs, but it's still in its early days. The quality of disability-related allied health skills is growing, but is it adequately funded for complex cases? Hopefully the Royal Commission into the Abuse of Children with a Disability will cast light on the areas that the NDIA has not adequately funded. Meantime, the management of the NDIA seems to have an internal battle between economists versus the need for disability professional expertise that understand some of the complexities of tertiary emotional behavioural services provision. I hope that wedge politics do not prevent the development of collaborative, multi-agency, multidisciplinary systems that have been so valued by families. One of my concerns is that the recent NDIS health agenda is driven by other priorities, such as dysphagia support for those with feeding problems, or physiotherapy support for those with cerebral palsy, and mental health support for those with long-term psychosocial disability from chronic psychosis and personality disorder. Meeting the needs of high-needs young people with IDD can get lost and needs continued advocacy. We live in an era where we should expect expertise and affluence to grow. There are now skills and knowledge that weren't there a generation ago. I feel all parents can aim for a good enough quality of life for their child with a disability, but raising a child has never been easy. I started this talk with the question, are we there yet? We certainly have not arrived at the destination to value all children equally. I've given a bit of a map with different signposts and roads to explore further that still allows individuals and their families to discover their own path. However, I am a believer in miracles with the changes I regularly witness in these families. Am I witnessing the development of self-belief and a sense of direction with a little step up that professionals' intervention provide? Perhaps comparisons can be made with the fable of the Wizard of Oz. Dorothy and her pet dog were swept off course by a cyclone, such as happens when you find yourself disorientated with a child with an intellectual disability. But miraculously, With the brain, the heart, and the courage of unlikely friends that she met along the way, she was able to find the yellow brick road and get home. As a postscript, I'd like to mention that in this article, in this presentation, I refer to a lot of other articles. Firstly, our textbook will shortly be available on our SchoolLink website. I shall also be turning this talk into an essay for our journal, which will identify the references, including many hyperlinks. Lastly, a reference list will also be available from the website and will be downloadable. Thank you very much for listening.
Thank you, Dr. Dossiter. That was a really great talk, and I personally loved the focus on the holistic presentation of the child with a disability and the family as well, so that's really appreciated. We've got lots of questions and we've got about 20 minutes, so I'll start with the first one. What is the best ways you've found to connect children and families into a community?
That's a challenging question.
I imagine there's lots of regional differences because we're, in a different region to what you are.
It's child psychiatry used to be very community orientated, and it was Thatcher that said there's no such thing as society. Well, I think that increasingly we're finding that societies are actually the bedrock of human well-being, and I think there needs to be an increased focus on supporting community activity. And again, it used to be religious organisations. I think it is for a lot still, but there need to be also secular processes of support through friends, through work, and through welfare agencies and the NGOs. So it's about going out there and creating your own connectivity is what I would say.
Yeah, thank you. Okay, there's two questions here that are similar, so I'll do that. If parental training is of utmost importance, how can we ensure that this training is available to parents? And then somebody also asked which services on the Central Coast provide the Stepping Stones parenting program, and could this be posted on the Health Pathways site?
I think I'm trying to advocate for access to Stepping Stones. As I say, it has the best quality evidence, and our society should be driven by high quality evidence. As I say, New South Wales was actually the pilot site for the seminar version and for the primary care version, and they too have been found to be highly effective. So that there are a network of available clinicians experienced in Stepping Stones training, and I suspect that our SchoolLink website may have a list of some of them. As I say, we have some scholarships available at the moment, and we're aiming to provide a webinar-based Stepping Stones seminar on Stepping Stones. But I would still like to see it more actively endorsed and funded by the NDIS.
Yeah, okay, thank you. I'm sure that's going to be good news for people knowing that it's going to be an online offering at some stage. The next question is, what advice to clinical teams would you give who want to build better collaboration with other agencies and disability supports for children?
I think my experience is that it's the clinicians you meet, the disability-based clinicians that you meet through your patients. I always struggle with the idea that, there probably is more now than 500 disability-based NGOs in New South Wales, and how could a team of 4 people possibly relate to 500 agencies? And so there is no system-based approach to this. We certainly are interested in, we have this project called the Transfer Care Project, which is our NDIS residual funding project, in which we're trying to build up partnerships with clinicians that we know that we know have competence, whether it be general practice or disability-based clinicians. So it's about building up networks of the people that you find are experienced and valuable. So it comes back to personal contact in the end.
Yeah, yeah. It's great advice, but it always comes down to relationships, doesn't it?
It
and
does.
yeah.
In some ways, smaller communities have closer net relationships, and so in some ways, smaller towns, you know who your NDIS people are, and you know who your DCJ person is, and you often can have, as I think has happened in the Central Coast. I just marvel at the disability health NDS and DCJ networking that's been established, and I think that's a reflection of small is better, in fact.
Yeah, yeah, thank you. Another question is, how can schools effectively help parents of students with IDD? It really comes down to the same things that you're saying. It's about relationship building and collaborating with partners.
Yeah, I think we have to trust schools significantly. I think traditionally they were the source of special skills for kids with IDD. It's a huge organisation, Department of Education, and they work very hard to meet the growing needs. I think it's about maintaining partnership and respect with them. It's the essential ingredient.
Yeah, thank you. And our last question for tonight, we might end up finishing 5 minutes early, is how is the IDMH hub going, so Intellectual Disability Mental Health Hub going?
Well, it's an exciting initiative. Basically, we've received funding for 2 days a week for a psychiatrist, a psychologist, a social worker, a service coordinator, and 1 day a week of an occupational therapist. And that's certainly enhanced our capacities. What has been great is our team has had this statewide recognition, which enhances our approaches to having partnership. And to some extent, it's authorised us both to have a standardised model of care whereby we try to provide limited consultation. So it's really a second opinion process for a case that is already owned by paediatrics and or CAMS. We require a medical referrer, but we will also work in the most efficient way possible by discussing cases. For example, for me, if I can help a paediatrician sort out what they might do next to help a family on the telephone, that's a much more time efficient process than seeing a patient for 2 hours and writing reports and putting it all together. Similarly, we provide the same sort of service for allied health to allied health. So there's this flexibility of response, and then there's these capacity building initiatives that we've mentioned some of, like the webinars, like the Stepping Stone scholarships. Our transfer care project is going to establish a mental health first aid program for intellectual disability, which is a first from the same mental health first aid organisation that many people will be familiar with. And then we've had some scholarships around our Westmead Feelings program as well. So we're trying to increase interest, skill, and therefore professional capacity. And our aim is to help people feel confident with these cases. And I think I feel very encouraged with this sort of programmatic approach, that we actually feel that people are more responsive and there is better connection between, the private paediatricians and the CAM services. And so it's early days. It's very exciting, and we're going to get an external evaluation, which will be reported back to Department of Health. And I look forward to that.
Thank you. That's comprehensive answers to those questions. So thank you for that. So we're going to finish the webinar now. So just a bit of a reminder to fill in the poll, not a poll, it's the evaluation. We'd really value your feedback, and we've got another webinar coming up in May, and you'll get an email from the PHN giving you the specific date for that. And the next webinar is Vince Ponzio from the Ministry of Health presenting. So that should be a really interesting wrap up to the webinar series. So thank you very much for attending. And just if you have other colleagues that couldn't make it tonight, please let them know that the recording of the webinar will be on the PHN website. We do think it'd be great to spread the information that we've had tonight just to build capacity on the coast for our IDMH families, not just the participants and the children. So thank you for attending, and good night.